Thank you, Jill. Michael?
So when I introduced myself a moment ago, I introduced myself as the founder and president of Dreams Over Drugs Foundation. What I neglected to mention is that I'm also a recovering heroin addict, 9 years. Thank you. When I was using, I never thought that it could possibly get any worse and the problem could ever get any bigger, and I was definitely wrong. But through my recovery, I couldn't help but take notice to all the families that were suffering and, all the young people that we were losing. It seemed like every week, you see something in the news or in the newspaper, and what myself and a couple of my colleagues did, we got together and pretty much we came up with this idea that we were going to go into some of our local schools and talk to the kids and kind of share our experiences with them and take it from there. And we started out, we went to Union Endicott first, and it kind of just grew from there. So we've been going from school to school, doing presentations and health classes, and even in auditoriums like this. I've actually done a presentation in this auditorium before. So it's been really good. The students are really receptive to what we tell them. And I think, the majority of them probably know someone or have a loved one that is addicted or was addicted. So they really see the need to kind of learn about it. And we're just getting really, really good feedback, really positive feedback, doing these presentations. So I'd like to thank you for having me. And
it's an absolute pleasure, Michael.
Thank you, sir.
I applaud you for your efforts and your sobriety.
Thank you.
Thank you
I
kindly.
appreciate it.
So Penny and Lisa, do you, from a parent's perspective, do you think that these community events are helping reduce the stigma surrounding this issue?
I absolutely do. I mean, I've done quite a few different panels, and the people that come up and talk afterwards, you get the community talking to you. And I remember one panel that we did, and I'm sorry I don't remember the place, but the mother came up to me and she was so excited, and she had her 2 sons with her, and she said, "I remember you from the first time you spoke." She said, "And my son was sitting right there." She said, "And now I'm bringing my second son to hear you speak." And she said, "You know what? When my third son gets a little bit older, he will be coming to one of these panels." So they're really opening up, and I think it's really opening up the conversation with the children as well.
Great. Penny?
I certainly agree with that. I also think that people who may never have thought about this or dreamed that they would be involved in working on this because of our voice and our advocacy Jill spoke about the Endwell Rotary. I had Carmela come to the Binghamton Rotary and speak, and that spurred an interest in someone from Rotary to look at a Rotary International grant to help with some additional funds and treatment here. I know as I was struggling with what I was struggling through with Johnny, I had that fear constantly that people in my professional life would find out what was going on, what a mess my family was. And when it all finally fell apart, a client that I had worked with for over 30 years came to me and said I had no idea, and I also had no idea what a terrible epidemic this was in our community, and he has since become very actively involved. So yes, I do think that all of these forums, all of these workshops, all of these voices are making a difference in the stigma. This past Monday, The Guardian, which is an international newspaper, printed an article about 2 families who lost their children. Mine was one, and also a family that was very much affected by addiction. And I was amazed at the people who reached out to me. So yes, I think our voices are helping lift the stigma.
Yeah, strength in numbers, right? I think that's clear. George, could you talk very briefly about what you're doing over at the Children's Home in terms of prevention? And I know the last time you and I spoke, you talked about a new program that you were going to spin up. So could you talk about that a little bit?
Certainly. Thank you, Senator. I know one of the thoughts coming here was what's working or what we need to do, and I think really what you're evidencing here is collaboration. And I'm really excited. You know, I've only been at the Children's Home for a short period of time, and one of the things I heard is that some of our children who would normally come into a facility like the Children's Home, but also had substance abuse issues or challenges, were having to go outside the community to receive the services they need. So they were away from family, away from friends, away from the positive aspects of their life. So in trying to address that issue, we really saw the best way was a partnership. And I think what we're evidencing here. And I'm really pleased and proud to announce that with Commissioner Johnson's support, that Carmela, through ACBC and the Children's Home, are joining in a partnership to make a small contribution. And that is that we're going to have some adolescent treatment options available initially for young people being served by the Children's Home. Some of them in our community programs, and some of those that are in our residential programs. And I think we'll be able to keep a few more young people closer to their supports. And that's just a small thing, but it's a model. I think it's a model that you know, in terms of this forum, that the more we collaborate, the stronger we are, the more we work together. And if I could just add, while I'm speaking, Senator, one of the things I think I would hope that the legislature would remember is the toll that addiction takes on children and other caregivers, and not just immediate, but the legacy. And I think I can best explain that with two very quick stories of things that have happened to me. I was working with a 10-year-old boy recently who wasn't in class. And I said, "It's math class. Why don't you go in? Math can be fun." And he looked at me and said, "You know, I really can't go in right now. I found out this morning that my mom is going back to jail, dealing with her addiction and her substance abuse." And so that issue was lying him, and that was math, his ability to grow, his ability to learn. And there was a young woman, 13 years old, within the last 2 weeks, who just came into our care, who on a phone call with people there supporting her, said, "You know, Mom, you need to either choose the needles or me." And those stories, I know, for many people on the panel are quite common, and they're aware of them. But the issue and the challenge is that the effect that this trauma has on those young people, on their brain development, on their ability to learn, their ability to feel joy, their ability to form supportive and trusting relationships. So I think there's a lot that we need to continue to do to make sure that the services and supports are there for children. And if I could also put in a plug for parents, many times grandparents and relatives who are caring for children while you know, a primary parent is dealing with addiction, that grandparents who are parenting, again, need all the support that we can provide. They need the access to services so that we can help children grow and develop, because if through the trauma of this addiction, if we don't help the children recover so that they can grow, they can learn, and they can form relationships, we're just going to recycle an issue. So I would hope that the task force would look for any ways that they can to provide those additional supports to children affected by this.
Thank you very much, George. Just want to kind of change gears a little bit if we could. And John, I think I'll allow you to start this portion of the conversation about harm reduction, what we're doing. If you could speak specifically about Narcan in the community and needle exchange. And then Ray, if you'd be so kind to talk about the deployment of Narcan from an EMS and fire and law enforcement perspective. And then once we're through with that, I think we'll change gears once again and start to talk from a law enforcement and a prosecution standpoint and what we're doing. So, John?
Wonderful. Last year, the staff at the Southern Tier AIDS program distributed 1,500 Narcan kits. Too close, I guess. That's just in our local area. According to the New York State Department of Health, naloxone was administered during 11,992 emergency medical service calls in 2014. This was a 57% increase from the previous year. This is a good thing. Those are lives that have been saved. Let's go back to harm reduction. A lot of people don't know what harm reduction is. That's what syringe exchanges do. And the easiest way to nutshell it is we're trying to keep people alive long enough to quit using drugs. We know that even in the midst of active addiction, we can prevent some of the harm that arises from drug use. This is why your personal doctor agrees to continue seeing you even while you are smoking, drinking alcohol, eating cheeseburgers, all those things that we all do but we know we shouldn't. She knows that continuing to treat you is more effective than abandoning you and waiting for you to, I'll put this in quotes, hit bottom. The bottom for some people is death, and we can reach people before they get there. So what is working locally in our battle against heroin addiction? Well, the syringe exchange programs are working. They're preventing HIV, Hep C, abscesses, heart infections, and serving as an entry point to get people into substance use treatment. Our syringe exchange programs, for people who don't know this, have dedicated staff that all they do is put people into treatment all day, every day. Very soon, we'll be providing the services of a physician and a registered nurse in our Ithaca syringe exchange program to prescribe Suboxone, wound care, and teach people proper injection techniques, again, to avoid infections. These interventions are going to reduce medical costs, keep people out of emergency rooms and hospitals. I heard someone mention earlier people going to the ERs and nothing being done if they leave against medical advice. And you should know that Alan and I have been having some discussions recently about those folks don't have to get nothing when they leave. They can be referred to the syringe exchange programs, or perhaps, my staff can even come out and meet the person before they leave. That would be ideal. So it's not a perfect solution. It's not treatment. But again, hopefully it would keep the person alive so that they could rejoin their family and get clean eventually. If I was going to ask for a wish list, I think that probably some more money for medical services in the syringe exchange programs would be helpful, again, in the hopes of keeping people alive and funneling them into treatment. These services should probably be expanded. Within the last several weeks, I've been fielding calls from Elmira, Delhi, Hancock, Walton, and other small towns from people asking me if we can bring the syringe exchange van to their locality and offer our services. Currently, we do not have the staffing to do that, but it would certainly be helpful, it seems, if people are making the calls to me. I'm a big fan of medication take-back days. I don't think that we have enough of those available for folks, and we've been doing some research on it up in Shenango County. There's a very active group there. I've talked to some folks lately who say when they do these, they get garbage, like 32-gallon garbage cans full of prescriptions. That sounds like a ridiculous amount, but go home tonight and look in your own medicine cabinet. I think you'll be shocked at what is kicking around in there. We all just look past it when we go to get the toothpaste, but there's probably some things in there. And also, I would certainly like to make a plug for an expansion of medication-assisted treatment, like Suboxone and methadone. Thank you.
Senator O'Mara has a couple of questions, if you'd be so kind.
Yeah, I would just point out, in this year's budget, in addition to the $165 million we get in there for addiction services, there is an extra $1 million in there to help set up more permanent drug collection sites in communities, so that it's on a more regular basis, and you don't have to wait to or see it, have to see the notice of the event. So I think that's going to be helpful in that regard. With regard to the syringe exchange and those programs, and this increase in the heroin epidemic that we've had. Are you seeing, and maybe not just you, but anybody here in the health community, increases in the incidence of AIDS or Hep C or those types of health issues as a result of reusing syringes?
You're not.
You're
As a matter of
seeing
fact,
that yet?
no, as a matter of fact, we have very good data from the Department of Health. If you look back at the AIDS epidemic, in the early 1980s, about 52% of HIV infections were due to people sharing injection equipment. That number now is 3% of HIV infections every year are due to people sharing injection equipment. So that is an unqualified public health slam dunk of a success.
My district includes the city of Ithaca, which has come out with a proposal for pursuing a heroin injection site in the city for addicts to come in and actually shoot up heroin on the site. And I think that speaks to really the extent of the problem that we're having here. I don't personally agree with that. Frankly, was quite taken aback by that proposal when I first heard of it. But since this is your area of expertise, do you have any thoughts on that type of a program?
Certainly, I do. These type of facilities are operated in 66 different cities in 10 different countries, and they have been operated in those cities and countries for decades. There are literally hundreds of studies about what happens at these facilities. And if you look at the research, what it says is that they reduce overdose deaths. They do not encourage drug use. They provide an treated treatment. They reduce risky injecting and transmission of infectious diseases. They improve the public order by reducing discarded syringes and public injecting. They reduce crime, and they're cost effective. So that's a quote, of course. But what that all means is you don't have people doing things like injecting in the bathrooms of local businesses. You don't have people discarding syringes. The one that operates in Vancouver, you have a detox right upstairs so that when people decide they've had enough, they can just literally go upstairs and begin the treatment process. So I understand that these ideas are difficult for some people, and that's okay to struggle with these ideas. They are radical proposals. But I think we're at a place where perhaps we need to entertain doing something radical.
All right, well, thank you for your perspective on that. I do have trouble wrapping my arms around it, for sure.
You're not alone.
With that. But it certainly, what I think it really highlights, just the extent of the problem that we have, that we're even considering measures such as that. But I do appreciate your input on that.
Ruth, what about in Shenango County in terms of Hep C, HIV? Ruth, what are you seeing? Let Ruth talk real quick.
Actually, it was the Hep C numbers that were climbing that caught our attention before we even started paying attention to the heroin use and epidemic, and that came to our attention through our public health, and then that began the conversation. And it was actually in that we were able to pull some folks together that were the beginning of a substance abuse prevention coalition that initially was focusing entirely on this heroin epidemic in Shenango County. The AIDS numbers have always been quite low, and I don't believe that there's been any movement in those numbers, but the Hep C was definitely catching our attention, and we continue to monitor that.
John, very briefly, I know last time I was in your company, you talked about the cost associated with hepatitis C. Could you hit that for the group out here and for those on the panel? How
Sure.
expensive it is to treat that?
There are some very new and effective medications that a 12-week course of treatment is anywhere from $60,000 to $90,000, depending on the medication that your doctor prescribes. There was a recent report on Medicaid, and I think it was saying that for the third quarter of 2015, 10% of total Medicaid pharmaceutical costs were due to hepatitis C drugs. So that's just the medications. That's not the full course of treatment. That's the meds. And then on top of that, you have, lab work, doctor's fees, and those sorts of things. So it can easily reach $100,000 per case.
Alan, what about in the UHS system? Are you seeing an increase in Hep C and the like?
In the hepatitis C area, we are, particularly in our methadone clinic, where, probably 88% of the people admitted are using IV. As John said, we've seen very, very little HIV change with this, but we have seen hepatitis C. The other thing relative to the cost of hepatitis C treatment, prior to the advent of these newer medications, the treatment of hepatitis C was with medications that would enhance profound levels of depression in many of our patients, and so attempts to treat hep C resulted in substantial relapses into substance use, which then starts the cycle all over again. So there's an interplay between treatment of hepatitis C and relapses with substance abuse. We're not seeing it as much with the newer medications, but it has been a long-standing issue.
Thank you. So let's go back to Narcan. Ray, could you hit on what you've been focused on in your efforts in terms of first responders, law enforcement, and the like?
Certainly, Senator. In early February of 2014, I was approached by Sheriff David Harder and then Captain Fred Akshar, his law enforcement commander, for assistance in establishing a program to train and equip law enforcement officers with naloxone, which was a medication very familiar to me. We've used it in emergency medical services for decades. We quickly got that program up and running. Folks at the New York State Department of Health AIDS Institute, which administer the regulations at the state level, told us it was one of the very first programs in New York State to train and equip law enforcement officers. We quickly got that program up and running, and the first case was successfully treated the following month in March, rather famously now. Since that time, we've been joined in the effort by virtually all the municipal police departments in the county, law enforcement agencies at Binghamton University and SUNY Broome Community College, the county security division, and unfortunately, when we started this program, we were seeing near-fatal overdoses in this county at the rate of 1, 2, maybe 3 a week. I can tell you now, sadly, it is an everyday, often several times a day occurrence in this county. What I can tell you is that we are prepared to handle these overdoses if we are called and are called in time before it becomes irreversibly fatal. We can predictably, reliably resuscitate these overdoses. Naloxone, of course, does not cure addiction. It merely provides another opportunity for the individual to address the addiction problem. Going forward, again, parallel programs have equipped emergency medical services and fire service responders with naloxone as well, and we're well equipped to treat the overdoses when they come. It's the underlying problem that has yet to be solved.
I don't mean to put you on the spot, but do you have any statistical data since we began distributing it in terms of how many lives we've saved? I know you're clearly going to speak about Broome, but since we started to distribute it to the masses, if you will, law enforcement, EMS, fire.
Well, I can speak to the law enforcement program because they report directly to Dr. Ryan as the clinical director of the program and myself, and there's been 64 cases since the program began in 2014 involving 5 law enforcement agencies here in Broome County that have actually administered it. In many cases, the naloxone is administered by fire or EMS responders, and they have a separate reporting system. So. Certainly their use of naloxone has surged over this time period as well. So it's an everyday occurrence, but if we're called in time, we have in all cases really been able to reverse these overdoses.
What about in terms of funding for Narcan? I guess I'll ask all three, John, Dr. Ryan, and Ray. Are a lot of agencies self-funding these programs? I know A.G. Schneiderman put up some money, but that money is used and gone. So is there something that we can do, my colleagues and I, to ensure that?
A sustained source of funding, specifically for emergency responders in addition to the replacement of naloxone actually used on patients, there of course is the fact that this is a pharmaceutical with an expiration date typically about 18 months by the time it gets to the end user, and it needs to be replaced periodically, which is really the major part of the cost.
Okay, thank you. John, is there some talk about a syringe exchange in Chenango County?
That is under discussion. We've certainly rolled that out in the substance abuse coalition, and I think that many people in the community are on board with the idea. It's not an idea that you will ever get 100% of the community on board with, and that's okay. We have sent out letters to the state level representatives, because that's the last step that the AIDS Institute has asked us to take at this point, to see if there are any concerns or objections.
So let's talk specifically, let's change gears and let's go to law enforcement and prosecution if we could. And, let's focus our energy right now on Chenango County. So I would ask Sheriff Cutting and DA McBride to weigh in on issues that you're being faced with in your particular jurisdiction, and again, where my colleagues and I can be helpful, and then we'll move to Tioga and Broome and talk about some of the things we're doing there from a law enforcement and a prosecution standpoint, if that's okay.
Sure. Sheriff, please go.
Sure. I guess I'm going to go back probably about 7 years ago, how it started for us. I was in a local restaurant with my son. He was then, I think, 7, 8 years old. We had gone in for breakfast. The girls had gone shopping. You know, life was good. And we walked in, I sat down, and pretty soon I was inundated by people in this community, small community, part-time police department, and their concern with the drug problem that they had in that community. And it got so bad, I mean, it was a pretty contentious point, and I made a commitment to them, you know, look, my son's here, I will be back Monday morning, this was a Saturday morning, and I'll meet with the business leaders in that community, and we'll address this issue, and going forward, we addressed that. And then we really started taking a hard look at what was going on, and we assigned people specifically to narcotics investigations. And in that next 2 years, we probably made over 200 arrests specifically related to heroin in Chenango County. Some of the issues and problems we have in Chenango County, it's a very rural county. Again, resources, we have 23 people, includes the undersheriff and myself, in law enforcement specifically. We rely heavily on the public. That gives us information. We have several ways that the public can get us information anonymously. We continue a lot of those investigations. Many of those people come into the jail. They go through a terrible time detoxing from drugs, heroin specifically. One of the things we're talking about now is having a door-to-door type thing. Once they come in, they're detoxed. Prior, what we would do is we would release inmates back out on the street, and many of them had no resources. There's nothing. They're going back to the same problems, the same issues that they came from, and they would fall right back. And again, it's a revolving door, and they turn around, come right back into the jail, you know, sometimes within a day or two. What we're trying to put together now, working with mental health, DSS, and a lot of the service drug court, drug and alcohol in Chenango County, is when those people are there, we have them detoxed and kind of parent through. They're going to interview the inmates and see who seriously wants to get into treatment, who wants help. You're going to have the people that are going to give you lip service or not going to really want help, and then you're going to have those people that do. We're going to look for those people that sincerely want help and try to get them a door-to-door. Once they are released from incarceration, that we can take them right to a treatment facility so that they can get help. We feel that that's the best time we're going to have in the public safety system when we have them to get them help. One of the things we're seeing now is we have a big mass change in heroin. It's changing now to meth and the one-pot method. We're seeing a tremendous influx now of meth. We've probably made close to 40 arrests in the last year related to meth and the one-pot method. It's extremely toxic, the chemicals that they use individually by themselves, and they combine them together to create this, and they're just disposing these chemicals all over. We find them in state property, state land, communities, parks. So we're now shifting gears a little bit from heroin. Heroin, while it's still extremely prevalent in Chenango County, we're not getting the large dealers like we did initially. We pretty much attacked that head on. We're getting a lot of smaller dealers that are using to supply their own habits, and they carry a very small amount, so they can't be, caught with a lot. They have stash houses and that type of thing. Moving forward, public education, I think, is extremely important. Again, we're not going to rush our way out of this problem. It's going to take a lot of different organizations coming together to address this issue. And I think, these forums are great to allow us to build the capacity and direction that we're going to need to address this.
Thank you, Sheriff. DA?
Yeah, thank you. Thank you, everyone, for giving me the opportunity to speak. Shenango County is a small rural county in upstate New York, and we're a history of farm communities, and this is a very strange problem to have in our community. And a problem that didn't develop overnight. We've always had a touch of heroin over the last 30 years, but over the last 10 years or so, we've had a tremendous problem. One of the ways I was introduced to the heroin problem is by covering, I'm the DA, so I do the felony cases and do the murder cases, but every once in a while I got to cover the justice courts in every small town. And in the small town of Sherburne, I was covering a case, and there was a kid there with a John Deere hat, looked like he just got done haying, and he was in front of the judge. And he was there for possession of heroin. I couldn't believe it, that this had come to our town, and this is the face of heroin now. Now, as we know, over those past 5 to 7 years, heroin's come, it's not only in Shenango County, it's all over. But in our small little county, I get to see the people that have grown up, that were on my Little League team, and that I've seen. There are two that come to mind the last year. One of them had an overdose and was actually brought back from Narcan, and he's done very well. He's completed his treatment. He's completed his treatment court, and he's done very well on his road to recovery. Another gentleman who was from the city of Norwich had been battling with heroin for a long time, and he lost his life to his addiction. So we've seen it all, and it affects the families. It affects everyone in our community. It's not just a poor person or a rich person. Everyone is susceptible. So what are we doing about it? We're working as a group to try and get the word out. And one of the groups that the sheriff spoke of, and I'm sure the head of our alcohol and drug services is going to speak to today, is we're trying to work together to see what we can do for prevention. And what we need to do, and even being here today, we need to, instead of the groups that are going out to the schools, that's great, but right now, this has been about a 10-year problem. We have to change the programs that are in the schools. It shouldn't be just myself and everybody else who can to make the time in their day to get that done. It's a health crisis. When I was a young man, they started health class, and we talked about it. It was to teach us all about the things they thought we knew in the 1970s. Right now, we need that mandatory education about the involvement of drugs, and specifically heroin, because as we all know, heroin is different. It's a lot worse. When we were growing up, we knew that you could do a lot of bad things in life, but if you used heroin, you'd die. Our kids don't know that. And whether it starts with the pills, that it mostly does, we need to do something about that. The next thing we need to do is, I spend a lot of my time, and Stephen's going to tell you, is we put people to jail. And in the beginning, when I did this, I was really against putting little kids to jail, young kids. But to be honest, I believe, at least initially, for those 5 days, 7 days, and we're saving their lives. But what we need to do is be able to get treatment for those kids so that we have a place to put them. So if we decide that we want to make sure that they're supervised and they have a place to go, that we could do that right away. That is impossible right now. One of the real problems is that in our county and throughout the state of New York, the people right next to me who are the experts in alcohol and drug services, their hands are tied. If I am a heroin addict and I need help and I go to them, they don't have the ability to assess me right away, and they have to send me down the road for an appointment in 2 to 3 weeks. And then not only that, but they can't refer me to all the open beds that are available in New York because they're not allowed to do that unless they have a full assessment themselves. We need to change the rules and regulations. We let them do their job, and we allow them to send people to beds that are available in our state so our kids don't have to go to Florida and everywhere else to get the services that they need. Once again, it's an ongoing problem. If we get the prevention, get the education in the school system, and 2, get the services for the people that need it. One last thing. Everybody who's in jail right now, when they are released from jail, no matter whether it's 2 months, 3 months, 4 months, when they were on crack, when they were on cocaine, they had at least a good period of time to change their life. My experience is if we're letting these people out without the services there, a lot of them are dying of overdoses almost immediately because they're taking the drugs that they took beforehand, their bodies aren't used to it, and we're losing bodies all the time. We can't continue at this rate, especially by regulations by the Senate, by the government, to allow the people in alcohol and drug to get these people in right away. And it's a crisis situation, and that's my request.
So let me know we're going to... Though we were going to continue down the law enforcement track, but allow me to digress. And Ruth, can you speak to that? Because I need to be educated on the hurdles that you're faced with as the DA spoke.